Welcome back to ACE to AMC. We have another high yield AMC style question for you guys. This is a high yield concept not only for the AMC but also for the general practitioner examinations as well. Let's get straight into the STEM. We've got a 50-year-old man who attends his GP for advice about bowel cancer screening. He has no past medical problems. His father was diagnosed with colorectal cancer at age 52, and his brother was at age 50, and he takes no regular medications. The question is asking us which of the following represents the most appropriate recommendation for this patient. They give you guys a moment, pause, answer, and come back. Okay, so up on screen right now is a diagram taken directly from the Royal Australian College of General Practitioners and also the Cancer Council Australia website. So we've got three key categories. So in order for a patient to be categorized in the low risk category, category 1, this category has a relative risk of about 1 to 2 times the general population. They need to have only one first degree relative with colorectal cancer, and they need to have been diagnosed older than 55 years. This group of people go through the National Bowel Cancer Screening program. So they get fecal occult blood test screening every 2 years from the age of 45 to 74. And this is updated guidelines in Australia from July 2024. In category 2, this is the moderately increased risk group. So they have a relative risk of about 3 to 6 times the normal. In order to be categorized within this group, you need to have one first degree relative diagnosed with colorectal cancer before the age of 55, or 2 first degree relatives with colorectal cancer at any age. You could also have one first degree relative plus 2 or more second degree relatives with colorectal cancer at any age. So this middle category is actually where our patient in the scenario is categorized, because he's got 2 first degree relatives with colorectal cancer, his father and his brother, and they both were diagnosed before the age of 55. So this places him within this category. Screening recommendations for category 2 is starting from fecal occult blood testing every 2 years from the age of 40 to 49. And then starting the colonoscopy from age 50 to 74, and we're doing that every 5 years. It's recommended that patients in this category should start colonoscopy actually 10 years younger than the youngest relative diagnosed, or at 50, so whichever occurs earlier. So in the instance of our patient, he's 50 years old currently, and the youngest diagnosed relative was his brother, which was at the age of 50. So this would mean that he should have started screening from 40. However, he's coming at 50, so that's why we should do a colonoscopy now and then repeat that every 5 years. Just quickly break down category 3 before we go through the options. So this is the high risk. So they have a relative risk of 7 to 10 times the general population. So these people have 3 or more first degree relatives with colorectal cancer, plus minus any second degree relatives of any age. People who also fit into this category are patients with known genetic syndromes. So this could include Lynch syndrome or familial adenomatous polyposis, so FAP syndrome. And screening in this group is still colonoscopy based. It's very similar to category 2 screening. However, we can start fecal occult blood testing screening as early as 35 years. So just going back to our STEM. So in our instance, our patient is 50 years old and he's got 2 first degree relatives, his father and his brother, and they're both under the age of 55. So this places him in the medium moderately increased risk category. And so it's asking what's the most appropriate recommendation. This would be option A. So colonoscopy now and repeat every 5 years until the age of 74. So that was just based on the categorization and the guidelines. So going on to option B. So option B is incorrect. So option B is saying colonoscopy annually from now until the age of 74. So this is a bit excessive and not really recommended. Colonoscopy annually would be reserved for something such as the high risk hereditary syndromes we touched on earlier, such as FAP and Lynch syndrome. When you're coming to to a situation such as this, you really got to weigh up the benefits with the risk. And so the risk of complications that can occur with colonoscopy are things such as perforation of not only the bowel but also other organs, bleeding, and there's always that anesthetic risk. Furthermore, this is not supported by Australian guidelines, particularly for our patient who is placed in that category 2. And in terms of public health perspective as well, this is quite expensive and not very cost effective. Option C, single colonoscopy now and no further test if normal. This is incorrect because a moderately risk patient such as ours requires ongoing surveillance every 5 years because of the elevated risk. So keep in mind that their risk is 3 to 6 times that of the general population. In terms of option C, when would a one-off colonoscopy make sense? This would be in an instance where someone with average risk who's doing a diagnostic colonoscopy for a reason other than colorectal cancer and they have no ongoing risk factors, or in the instance where a person's life expectancy is short and further screening won't change the outcomes. But in terms of this stem, our patient's got a very strong family history. Screening once is not sufficient enough. Option D, fecal occult blood testing every 2 years until age 74. This is incorrect. So this is what we would do for the average Australian who is in that category 1. So this patient in our scenario is above this average risk. So we're going to be focusing more on a colonoscopy based screening, not fecal occult blood testing now, especially since he's 50 years old. Option E, no screening is necessary as he is currently asymptomatic. This is wrong. And this is simply just a trap because screening is specifically for asymptomatic people. So saying we're not going to screen this patient because he's not showing any symptoms is a fundamental misunderstanding of why we do screening in the first place. Especially in regards to our stem and the patient that we have, it would be very negligent to not offer screening in this case. I hope you guys gained a lot from this breakdown. I know this video is going to be a bit longer than the usual ones, but we did touch on some important categorizations, particularly when it comes to colorectal cancer screening. If you guys like the content, please give us a like and a follow, and feel free to check out our YouTube channel for more content such as this. Thank you guys.